Good evening, I'm Mike Knetter. Welcome to the UW Now Livestream series, where we bring you experts from the UW community talking about timely and important topics. Last week, we learned that the US had the single largest drop in life expectancy since World War II. What have we learned about COVID-19 transmission and treatment in the past year? And what can we expect with the deployment of vaccines in the coming months? And as COVID variants develop in different regions of the country, will these vaccines still be effective? When will we be able to safely visit our neighborhood restaurant or sporting events again? Joining us tonight are three UW researchers and doctors to discuss these issues. William Hartman is an assistant professor of anesthesiology, medical director of the UW Health Pre-Op Clinic, and the principal investigator for UW's convalescent plasma program. Nasia Safdar is a professor of infectious diseases, vice chair for research in the Department of Medicine, and medical director of infection control at UW hospitals and clinics. And Jonathan Temte is associate dean for public health and community engagement at the School of Medicine and Public Health. Thank you all for joining me. You've all been here before. I appreciate you coming back and sharing these important updates with our audience tonight. Our first speaker tonight is Professor Safdar, the Vice Chair for Research in the Department of Medicine and the Medical Director of Infection Control at UW hospitals and clinics. She leads the department in its mission to reduce and prevent healthcare-associated infections by identifying, testing, and implementing novel interventions. Professor Safdar received a Presidential Early Career Award for Scientists and Engineers in 2017, the highest honor bestowed by the U.S. government on outstanding scientists and engineers beginning their independent careers. In 2014, she received the John Q. Sherman Award for Excellence in Patient Engagement. She's a fellow of the American College of Physicians and a member of the Society of Internal General Medicine. She received her MS and PhD from the University of Wisconsin. And I will add, she was our first guest on this program almost 11 months ago. And this is your third time back, I believe. And I thank you very much for joining us and giving an update on all things COVID infection. Professor Safdar, take it away.
Thank you very much, Mike. And thank you for the opportunity to talk about the state of COVID-19 today. If we could have the slides. Let's go on to the next slide. So I think this map will not come as a surprise to anyone. I think we've all recognized that the ravages that this pandemic has wrought upon the globe far exceeds anything that we have seen in recent and probably long-term memories as well. So the darker colors on the map indicate the countries that have borne a high volume of infections and have seen a considerable burden of COVID-19. This is not to say that it hasn't really had an impact globally. I think some of the countries where the case count is difficult to ascertain and the resources aren't there for aggressively counting cases are likely underestimating the number of cases and the burden that this pandemic has had. It is a difficult number to look at, but if you look at the bottom of the slide, 111 million cases globally and 2.5 million deaths. I mean, that's just astounding. It's difficult to fathom, I would say. If you go to the next slide, we can see what the current state looks like in the US. You know, hard as 2020 was, I think there is light at the end of that tunnel. And what we're seeing here is the states that are in the Great Lakes region. So Wisconsin is at the bottom of that slide there. And it's hard to believe that just a couple months ago, we were in the midst of this massive surge and healthcare systems were being stretched to their capacity and literally bursting at the seams, looking after patients who needed medical care outside of COVID, and then patients who were also dealing with COVID. So you can see that on the left-hand side of this slide, the number of new cases continues to go down. The number of tests that are being done has gone up and down, is holding steady in some states, but has gone down in others. But the really remarkable thing, I think, is the percent positivity that continues to fall and is now in the single digits, whereas just a short time ago it was escalating and it didn't look like there was any end in sight. So overall, I think things are improving, but there's certainly parts of the country that just as throughout this pandemic, it was a regional pandemic, there were rolling hotspots, and I think we continue to see that there are parts of the country that are having a rougher time of it than others. If you go to the next slide, I think one of the lagging indicators of how badly things have been doing until very recently has been the number of deaths. And unfortunately, the United States really leads the world in the number of deaths that have been experienced here. Many, but not all of these, have been experienced by patients in congregate living settings, primarily skilled nursing facilities, where once you have even a few cases of COVID, it's virtually impossible to prevent transmission throughout that entire organization or that entire facility. And so these are not likely to dramatically change in the short term because these are lagging indicators, and as deaths are counted and certified and ascertained, this is often something that takes a longer time to turn around. If you go to the next slide, I think one of the sort of things that is causing trepidation in the near future and beyond is what happens with SARS-CoV-2 variants and how will they impact our mitigation efforts, our trying to return to normal, and just life in general. And of course, one thing to remember is that viruses mutate all the time, and there are variants that are occurring without our knowledge or without our consent. And because they are inconsequential in most instances, they merit little attention. However, there are more consequential variants, and every day it seems like there's a new one that pops up. Dr. Temte will talk more at length about the impact of the variant on the protection that the vaccine affords against the virus. But I think from the infection control standpoint, this is really important for us to really closely monitor because it may have implications for the use of PPE, for the shedding of the virus in patients, how long isolation precautions should be done, and all those considerations need to be handled and changed if it's necessary for them to be changed. Most of the variants that we're seeing here, as you see on this slide, has to do with the configuration of the spike protein, which binds more tightly, at least for some of the variants, to the host cell and makes it more easily to transmit. On the next slide, we'll see what the implications of these variants are. So for some of the ones like the UK variant, for instance, we know that it has the ability to spread more quickly in humans. I think it's a little bit unclear whether it causes the same spectrum of disease or does it cause more severe disease. We've seen reports pointing to both, and the truth is probably somewhere in the middle, I think. It doesn't appear to evade detection by diagnostic tests because the PCR test that we use typically has multiple targets, and so that test would still be positive no matter which variant you have. And we don't know whether the virus strains, the new variants, will exhibit resistance to some of the therapeutics that are available, and if so, to what extent will they be able to escape the effect of those therapeutics? I think what has been reassuring is that in terms of the vaccine ability to protect people, at least for many of them, it appears that even if the vaccine isn't, super stellar against that variant, it is good enough that it can still give protection to people who are getting it. If we go to the next slide, what you see here is things that we are learning just over the past few weeks, the syndrome of what's being called post-acute COVID. The press is calling it long haul. And what it really means is that there are individuals who have seemingly recovered from their acute illness, but yet have persistent symptoms. And there's a wide variety and a wide spectrum of symptoms that are being noticed. It's really unclear at this point if they're related to the initial severity of infection, or can people who have a mild initial illness still exhibit prolonged and persistent symptoms. And what's a bit challenging, I think, and the future will likely hold some answers here, but at the moment it's a bit challenging because the syndrome is still being defined. And so some of the things that people are trying to answer is, are these persistent initial symptoms or are these new symptoms that are being reported? And how do you distinguish between the sequelae of critical illness for somebody who may have been in the ICU for a week, for instance, will have fatigue and muscle weakness as a consequence of that, or is that related to a COVID symptom? And finally, a lot of the studies that have happened have relied on symptom-based reporting, but could there be silent organ damage that is happening that we just don't know about because most people will not end up receiving imaging studies or blood tests unless there's a symptom that prompts that kind of assessment. So there have been several studies at this point. Many of them have used patient-reported symptoms. Many of them are survey-based, but they all seem to show the fact that post-acute COVID is not uncommon. As many as half of the patients in this one study that looked at about 277 cases who had recovered, about half of them went on to have symptoms. And the symptoms range from having fatigue, persistent shortness of breath, loss of smell or taste that went on for several months. And even though, the loss of smell or taste may seem like a seemingly trivial symptom when you think about mechanical ventilation and shortness of breath and all the other things that COVID-19 patients need, for patients, it impacts the quality of life pretty dramatically when you're not able to smell or taste your food. Other things that have been reported are a persistent cough and just a feeling of being in a brain fog. If you go to the next slide, the largest study of this kind was just recently published in The Lancet, and they looked at the 6 months consequences of COVID-19 in patients who had been discharged from the hospital. So a bit of a caveat, these are hospitalized patients, so their symptoms were likely severe enough at the beginning that they needed hospitalization. But this was more methodologically rigorous than many other surveys because they took the time to administer questionnaires to all patients for evaluation of symptoms. And for a subset, they also did CT scans and ultrasonography and pulmonary function tests to better define the syndrome and not just rely on self-reported symptoms. And what they found was, which we'll see on the next slide, is that they had almost 2,000 patients. This is a study from China. These were adults who had been discharged from hospital recovering from COVID-19, and 76% of them reported at least one symptom at 6 months. So it's not quite the acute illness that we thought it was, that you would either, have complications from it, but eventually recover from it, and then things would go back to baseline. That does not appear to be the case. The most common symptoms were fatigue or muscle weakness and sleep difficulties, and a considerable proportion reported, not surprisingly, anxiety or depression at follow-up. Those that had more severe illness during their hospital stay also had issues with lung diffusion capacity and abnormal chest imaging, which is also not surprising. And there was decline of the antibodies in the blood over time, suggesting the potential for reinfection after a certain number of months have passed. So I think a lot more to learn about post-acute COVID, but it's definitely a high priority syndrome to characterize, to develop therapeutics for, and help people recover from. So finally, to conclude, what will the future look like? And I'm delighted if I'm wrong on all these counts, but I think what is likely to happen is that SARS-CoV-2 will become part of the repertoire of viruses that we see every respiratory virus season. I think the vaccines, being as highly effective as they are, which is wonderful, may or may not require boosters over time if we find that there are variants that require an extra vaccine dose or there is waning of immunity over time. I think it is likely that we will continue to see the ebbs and flows that are characteristic of a respiratory virus, and that come every respiratory season, we may find ourselves reaching for our masks, whereas in the past we were militantly opposed to it. I think workplace policies will need to adapt and change to respect the fact that people with symptoms of respiratory illness shouldn't be in the workplace, and there should be policies and procedures designed to support those people so that there is no pressure for them to be at work where they may expose other people, but rather take the time to recover. I think ultimately we will have to find a way to learn to live with COVID while using all the mitigation measures that are at our disposal, including, but not solely, vaccination. And I think for us, it's a high priority to pay attention to the negative long-term consequences of COVID, not just the post-acute COVID syndrome, but also the immense collateral damage caused by it in the form of other preventive illnesses that we will likely only know about in the ensuing months, and the effect on children of the lack of in-school learning. So I will stop there, and thank you for your time.
Thank you, Dr. Safdar. We don't have you on the show to be the bearer of good news. I'll try to get a more fashionable mask for next season. We'll come back to you with some questions very soon, but thank you for your remarks tonight. Very insightful, as always. Our next guest is William Hartman, Assistant Professor of Anesthesiology at the School of Medicine and Public Health, Medical Director of the UW Health Pre-Op Clinic, and the Principal Investigator for the UW's Convalescent Plasma Program. His laboratory focuses on quick implementation of therapy trial protocols to safely bring novel treatments from the laboratory to the patient. He's working on 3 ongoing trials with the Regeneron monoclonal antibody cocktail to be used in infected inpatients and outpatients, as well as non-infected household contacts as a method to prevent the development of disease. Bill, thanks for joining us tonight. Pleasure to have you back with us, and please share us an update on what you've learned about treatments.
Great. Well, thank you very much again for having me back. It should be remembered a year ago, March, when this came to our shores, we didn't have any treatments available. We were treating people with vitamins and hydrochloroquine, and we weren't sure where to go. So the fact that we've gone from point A to probably point P or so at this point is tremendous, and it's a testament to the physicians and the scientists and all the people who've devoted their time and their efforts towards making sick people better, and it's much appreciated. And so, as an anesthesiologist, I've been helping fight this on the front lines, but also I've had the tremendous challenge and privilege of being the principal investigator for several of the COVID clinical trials that have gone on at UW, and we'll highlight some of those as we go through this discussion of kind of the treatments and preventatives of COVID-19. And so COVID-19 actually gives us 3 different phases to attack. As we learn more about the virus, we are able to figure out new points to go after it. The best way to attack COVID-19, though, is in this pre-infection phase, where we can attack it with vaccines and also with mitigation methods. The best way to not get sick from COVID-19 is to not get COVID-19, and so that's our goal. That's where we're at. But if you do get sick from COVID-19, if you do get the virus, then there's two phases for us to really go after. The first is the viral phase, where the virus has entered your body and it's trying to get into your cells to make bad things happen to you. Its goal is to figure out a way to proliferate, to make more of itself so that it can go on then infect other people. Your body then is going to try to fight that virus, and that takes us to the third phase, or this host inflammatory phase, where your body is sending in everything it can to attack this virus, to get it out of your system, to neutralize it. But in doing so can cause this cytokine storm, where your body is actually causing more problems than we hope for, and unfortunately can make you very, very sick. And so if we can attack it early in this pre-infection and in the viral phase, we will do some good. Next slide. And so we'll start going through the viral phase, where we can talk a little bit about some of the antiviral medications that have come up, and then we'll talk about antibody-based therapies that we have to help neutralize the virus. Next slide. And so with the antiviral therapies that are available right now, including remdesivir, which is the drug that you've heard about most, the goal is to stop the replication of the virus as much as you can. And remdesivir initially was thought to be very useful, even though it was developed for a different purpose. They repurposed this medicine and saw that in a couple of trials here in the US, that it was actually decreasing the time that it took for people to recover. And it did so by a couple of days. Unfortunately, that didn't always correlate with the time to get out of the hospital. And so the understanding of the benefit of remdesivir wasn't fully elucidated. People didn't know, was it really working as well as they thought? Well, people were getting better from what we could see and from what the data was saying. But then the WHO did its own trial, the Solidarity trial, where it looked at remdesivir, and what they found was that it didn't improve mortality, intubations, or hospital length of stay, and consequently, they put out a recommendation against using remdesivir. But in the US, the FDA still believes much of the data that came under the US trials, and still is allowing remdesivir to be used in our patients under the emergency use authorization, or the EUA. Next slide. One of the most important contributions, I think, to the treatment of COVID-19 that came out of University of Wisconsin was our ability to use convalescent plasma very early in hospitalization. And we were able to do this because in March, we didn't have a big surge of patients, yet we had a huge supply of convalescent plasma. We had well over a third of the nation's supply for the first several weeks of the pandemic here in Madison. And so because of the work of Dr. Joe Connor in the blood bank, we were able to get type-specific plasma to our patients essentially as soon as they were admitted to the hospital. We saw that and published early on that it was anecdotal and it was a case series, but we saw that we were able to keep our patients out of the ICUs, off of ventilators, and get them out of the hospital sooner when we transfused them early, where the rest of the country, the rest of the world was using convalescent plasma more as a salvage therapy in the ICUs. And Dr. Arturo Casadevall, who led this effort in the United States to use convalescent plasma, wrote the email that you see on the right side of your screen here that said that as far as he was concerned, University of Wisconsin made the critical contribution to the plasma project of treating patients early. And when that experience got around, people began to do so and mortality began to drop. And that was a huge deal in the early days of the plasma story. And the middle screen just shows the benefits. This came out of from a paper from in Houston, but what you saw was that when patients were transfused with convalescent plasma, mortality decreased by about half. Next slide. And this is the survival curves from 16 trials worldwide looking at use of convalescent plasma. And each of these trials has different power. They had different protocols, and they were looking at different outcomes. But when you look at the survival curves based on the data that they had, you can see clearly that the transfused patients, the yellow line, had clearly a benefit of increasing overall survival when compared to patients who weren't transfused with convalescent plasma. Next slide. And so that naturally brought us to the next generation of convalescent plasma, essentially, which is the monoclonal antibodies. And monoclonal antibodies are the antibodies that are actually cloned from convalescent plasma. We look for the most promising, the most neutralizing antibodies that's in the convalescent plasma, and we're able to isolate it and grow it to huge proportions, and then give large doses of this to patients. And we studied this in conjunction with Regeneron beginning last June here in Madison on 3 different arms: the inpatient, the outpatient, and as a preventative in household contacts. Next slide. And in the outpatient trial especially, we saw that between day 1 and day 7 after a person had been given an infusion of this Regeneron monoclonal antibody cocktail, there was a tremendous decrease in the viral load. And so patients were getting better. They were feeling better within 1 or 2 days, but they were becoming less infectious. And most importantly, they were staying out of the hospitals. And in areas where the monoclonal antibodies are being used most commonly now, they're seeing a reduction of about 75% in hospitalizations. Next slide. And so these summarize some of the results that we've seen both in the inpatient and in the outpatient arms. The trial itself really took on a lot of steam once the President of the United States became diagnosed with COVID and revealed that he had received Regeneron's monoclonal antibody cocktail, and he himself called it a cure. I don't think it's a cure, but I think it's a very good treatment. And again, what we've seen is that in patients at risk of developing severe disease, when we treat them early as outpatients with the monoclonal antibody, we were decreasing medical visits and hospitalizations by 72 to 75%. Unfortunately, the inpatient arm hasn't been quite as successful. Many of these patients, those in the ICU who were already intubated or on high-flow nasal oxygen, received really no benefit from the monoclonal antibodies, which we would expect because they've moved into that inflammatory phase and out of that viral phase. But we're still looking at patients early in their hospitalization to see if the monoclonal antibodies can be useful then. But for the patients who are in the ICU, who are intubated, who are in high-flow nasal oxygen, the trial has been put on indefinite pause. Next slide. One of the more exciting aspects of this trial has been revealed in the last couple of weeks, and that is that as a preventative medicine, the monoclonal antibody cocktail is acting as a passive vaccine. And so in people who live under the same roof as someone who has COVID, when we give these people the monoclonal antibody as a preventative medicine, and I've never seen this before, but it was 100% effective in preventing symptomatic COVID. And so where this comes into play and where it's important is that, as Dr. Safdar was saying, in the nursing homes or prisons or other group home situations, if a person contracts COVID, we now have a way to keep the other people safe from symptomatic disease. Next slide. In the viral stage, again, early therapy is better than late. With convalescent plasma, if you use high titer but low, high titer convalescent plasma early, it can be very effective. And it's received an emergency use authorization by the FDA for that. The monoclonals decrease hospitalizations when used appropriately in outpatients. Again, that's been given an EUA by the FDA as well. And both of these are going to have decreased effects against COVID variants, but overall, in the interim, for right now, with the disease that we're fighting, these are both very, very effective treatments. Next slide. So the inflammatory phase, again, is characterized by this cytokine storm. And so once we've moved out of that viral phase into your body fighting that virus, the cytokines that are released by your body can cause more damage than the good that they can produce. Next slide. We weren't involved in this slide or in this study early on, but the ICU doctors here believed very much that steroids were going to be useful and helpful, and thank goodness. And then from England and then back on into the United States here, they saw that with the use of dexamethasone in the ICU, mortality was decreased by about 1/3 in patients with life-threatening disease. And so the steroid effects of preventing that cytokine storm or of lessening its effects was obviously very beneficial. In the last panel on the bottom right there, you'll see that if steroids are used early in disease, though, it might cause more harm than good. So it's really reserved for the person who is starting to use a lot more oxygen or needs to be intubated, but steroids are a very effective therapy in decreasing overall mortality. Next slide. Finally, in the pre-infection phase, there's two effective treatments. One are the mitigation methods, and the second are the vaccines. Next slide. So the mitigation methods all still apply. So washing your hands, avoiding crowded places, using the sanitizer, keeping your distance, wearing a mask, all of these things are still very, very important. And we should remember to do all these things even as the vaccines become more and more prevalent. Next slide. The COVID vaccines, as Dr. Safdar said, are very, very effective. The two that have received EUA so far, the Pfizer and the Moderna, both mRNA vaccines that have this 94-95% efficacy after 2 shots. Extremely effective. The one that we're studying here at the University of Wisconsin, the AstraZeneca vaccine, somewhere between 76 and 90% efficacy after the first dose, 82% efficacy after the second dose. And the Johnson & Johnson, which will be debated for EUA on Friday, has, again, a very effective vaccine, probably somewhere around 75% effective here in the United States. Overall, though, it's around 66%, so a little bit less. It should be remembered that the vaccines now are being used and studied in a time where variants are prevalent. The EUA vaccines, they've done science experiments, but we really don't know how effective they are on the variants at this point. And so we'll let Dr. Temte talk about that in a little bit. Next slide. So the status of our UW AstraZeneca vaccine, the enrollment is now complete, and we anticipate the efficacy answers by the end of this month. We're going to continue to follow up on all participants for the next 2 years. And I believe that the trial here was designed much better than those done abroad. And so I anticipate more concrete answers and less data ambiguity, which we've seen come out of the UK. We're soon to have a pediatric vaccine trial, likely to come here to UW, and we'll have more to talk about that later. So thank you very much.
Bill, thanks for fitting us into your calendar. I know you're double booked tonight and you won't be able to stick around for questions, but I'm sure your colleagues can help us out. So thanks for joining us and good luck with your next presentation.
Absolutely. Thank you.
Our final speaker tonight is Professor Jonathan Temte, Associate Dean for Public Health and Community Engagement at the UW School of Medicine and Public Health. As a physician and professor in the Department of Family Medicine and Community Health, he's served as a clinician, teacher, and researcher for 25 years. His research includes investigation of the relationships between communities, primary care, and respiratory viruses. An expert in vaccines and immunization policy, Professor Temte has served on the U.S. Advisory Committee on Immunization Practices, chairing its evidence-based recommendations work group. He's also on the CDC Board of Scientific Counselors. He chairs the Wisconsin Council on Immunization Practices and serves as medical director for Public Health Madison and Dane County. John received his MD and PhD right here at the UW Madison. So John, thanks for coming back and joining us tonight. The floor is yours to walk us through your outlook on things.
Well, thank you so much, Mike. It's a pleasure to be here. And I have to start out by saying that I have some incredible colleagues to work with here at the School of Medicine, Public Health, and beyond at the University of Wisconsin. Next slide, please. I'm going to be talking about vaccines primarily and the end game. And as Dr. Safdar had mentioned, things are starting to look better. But, next slide, we hit a incredibly terrible day yesterday with 500,000 people, 500,000 dead in the United States. I've heard that 1 out of every 3 people know somebody who has died. And keep in mind also, this is equivalent to the 1918 pandemic. And in 1919, we did not have supplemental oxygen. We did not have ICUs. We did not have ventilators. We did not have antibiotics, and we really didn't have any vaccines for influenza. We didn't even know influenza was a virus. So put that in perspective. But the good news is we're starting to turn the corner. We're seeing cases drop. We're seeing things improve. But even as we envision the end of COVID-19, we need to confront its overlap with 2 other public health threats: climate change and systemic racism. Next slide. At the origin of SARS-CoV-1 and SARS-CoV-2 is probably the effect of climate change on bat habitat. And if you take a look at the inset, this is a hot spot very, very close to Wuhan, China, where climate change has created conditions that have been favorable for bats. Next slide. As Dr. Safdar has mentioned, and also has Mike mentioned from last week, we, over the first 6 months of 2020, had a 1-year decline in life expectancy in the United States. But this has amplified the effects of ongoing racism and health disparity. Black men have lost 3 years of their life on average. Latinx men, 2.4, Black women, 2.3 years. So COVID-19 has to be taken into account in all these other things. Now, Mike was kind enough to pitch me some very slow softballs right over the plate. Next slide. And gave me some questions to think about. So first off, what percentage of the Wisconsin population has already had COVID-19 or a vaccine? Next slide. I don't have the answer, but we have some pretty good guesses. From surveys done on collected blood, we can identify approximately 24% of our state has now been infected. And if you look at the panels down toward the bottom of the slide, it turns out that those who are younger, 18 through 49, have about 28%. Those older, 65, or I'm sorry, 50 and older, it's about 14-15%. But it's out there, so we do have some benefit. Next slide. We also have vaccine that has been rolling out, and currently we're to about 13 to 14% of our state has received vaccine. And that's really, really good news. So next slide. If we put together what we estimate from serology or from blood, and we add that to the immunity from vaccination, we get somewhere around 37% of us are currently immune. Next slide. So question number 2, how many people need to be vaccinated for our restrictions to begin to lift? Well, it depends on what restrictions, but this is the way I think about it. We have to hit a herd immunity or herd effect threshold. And we used to think that was about 60%. And the way we get there is we add our natural immunity, 24% Wisconsin, and we have to make up the rest with vaccine, so 36. The way we get to the 36 is we have to multiply a vaccine effectiveness by the number of people who are willing to get that vaccine in the population. So in this example, if 38% of us get the vaccine is 95% effective, boom, we get there. However, next slide. This is where some of the material that Dr. Safdar was talking about comes in. We have now found the B.1.1.7 strain in Wisconsin. That was just last week. And now we're up to 6 of these being identified in our state and several thousand across the country. And why is this important? Next slide. Well, it's because the variant strains can make SARS-CoV-2 more transmissible. And if you take a look on this figure, we have across the bottom a measure of transmissibility of viruses, and going up the vertical axis is the herd immunity threshold. And if you hit the button one more time here, with the B.1.1.7, it pushes up the transmissibility, which in effect increases the herd immunity threshold we have to get to. So now we're looking at something like 80%. So next slide, please. So again, if we go back to this, we see our herd effect threshold now is 88%. And at the end of the day, it means instead of about 38% of us getting vaccinated, we have to push that up to nearly 60% to hit that herd immunity. Next slide. So the next 2 questions, with the new vaccines in the works, what will this mean for distribution? And how will local, state, and national vaccine policies evolve? Well, I'm going to try and answer these both together. Next slide. Well, as we get more people vaccinated, we move through different phases. And this is a slide I borrowed from CDC, but shows our phase 1, phase 1B, phase 1C, and phase 2. And I hate to break this to everybody, but in Wisconsin, we're already at week 11, and we're still in phase 1A. And the reason being is there just has not been sufficient supply of vaccine as of yet. Wisconsin is, comparatively speaking to other states, doing quite well in terms of distributing what we have, but we're just not getting enough. Next slide. So when we talk about the phases, 1A is our healthcare personnel and our residents and staff of long-term care facilities. And this represents about 10% of Wisconsin's population, and we're getting pretty close with this group. Next slide. The phase 1B for Wisconsin is due to start this following Monday. And this includes individuals who are living in high-risk situations, such as congregate living settings, and also public-facing essential workers, so 9/11 operators. The big one is educators and childcare, and the non-frontline healthcare workers, and so on. So we should be starting with these just within a few days. Next slide. Who's left? Well, it's the people, the important people with healthcare problems, and we really want to start getting vaccine out to them as well, and then other essential employment categories, and then everybody else. So next slide. So at the end of the day, what we need is safe vaccines, and we have them. Now we've had enough vaccine out there, about 50 million doses, for us to feel really comfortable with these vaccines. They are safe. They're incredibly effective. I believe on next Tuesday, March 2nd, we will probably have the Johnson & Johnson vaccine out and ready to roll. We need a reasonable stepwise allocation plan, and Wisconsin does have that as well. The distribution system is improving day by day. I just saw there are now 4 new sites being sponsored across the state that are state-run. But beyond that, we need this willingness to be vaccinated, and we need good communication going. And let's hit it one more time and give Bucky the shot. And I'll stop there, and we can open things up for questions. So thank you so much for your time.
Bucky always needs a shot in the arm, right?
Absolutely.
So, well, let's go to some Q&A, and I want to start out by addressing some things that I've been following in the media, various parts of the media at least, and that is, you know, Dr. Fauci getting a little bit of heat for, let's say, the evolving nature of the guidance, and, you know, what should we really do to be safe? And I think more recently he talked about double masking, and then I've noticed on social media and probably some national media outlets, there's a lot of talk about, well, there are studies that show that masks really aren't that helpful. And, you know, I feel it's important for us to ask our own experts. I didn't have you on the show because I know what you thought about this. This isn't a political show. I want to know, what do you think about the evolving nature of the guidance? How do you explain, you know, some of the slight reversals maybe, or changes in direction? And then particularly with masking, is it effective or not? And you know, where do you turn for evidence on that? And what would you say to people who are skeptical about masking?
I think we can answer this in 2 ways. I'm going to take the public health, and I'm going to ask Dr. Safdar to give us her reflections from hospital infection control. But I have one of my masks right here. And what we do know across the world, in countries that were incredibly good about masking and distancing, they had virtually no COVID. New Zealand is a country that has a population a little less than Wisconsin, and they had, I believe, 25 deaths total and less than 3,000 cases. Compare that to our experience in Wisconsin with 6,000 deaths and about 50 or 560,000 cases. There's no comparison. And in all the public health studies that have been done looking at the role of masking in particular, and masking and distancing, they have overwhelmingly supported masks, even to the extent where you look at state-by-state comparisons with mask mandates and adherence, you find differences, and the differences go in the direction you would expect. Places that use masks tend to have lower rates of transmission, places that don't have higher. But let me turn it over to my colleague, Dr. Safdar.
Thank you, John. I would agree. I think in the healthcare setting, it's pretty simple and self-evident that masks save the lives of healthcare workers. With COVID, there was this concern, does SARS-CoV-2 present an occupational hazard to healthcare workers, and are the rates going to be astronomically higher than they are in the community? And we didn't see that. There's certainly some cases that may be transmitted within the health system, but by and large, healthcare workers wearing PPE have been protected from getting occupationally acquired SARS-CoV-2, and most of the cases that we're seeing in them are coming from the community. I think masking is a pretty, for whatever reason, I think is a charged topic, and we tend to believe what we want to believe about the studies. But we have this tendency to expect that an intervention must be 100% effective for us to want to do it. And I think just as with everything else, masking is going to reduce the burden of aerosols that is going to be emitted from the wearer, and it's going to protect other people around them. But there will still be some transmission, which is why it's not a substitute for the distancing and the staying at home when you're sick and the quarantining and all of that. It is one of a suite of solutions, but a really important one.
I'll just throw in one more point here, and I think all of us can agree on this, that in general, wearing a mask is kind of a pain. Going to the grocery store and having to put the mask on, I don't like it. When I'm in clinic and spend my half day there in a mask, it's really hard. So we can all agree that it's a pain, but unfortunately, it's been a very effective pain. It works well, and there's going to be need for ongoing use of it.
I consider it the great equalizer, Dr. Temte. I don't know what you're talking about, but it is interesting. I think if we had a more aggressive approach with masking, we would be able to get the economy open more quickly, which seems to be what people want to happen. They just wish it could happen without masking and that there really wasn't a virus, I guess. But I think most of the evidence points to the fact there is a virus, and masking does help. And certainly we see that in a lot of countries, as was noted, not just New Zealand, but elsewhere, and certainly in medical settings. So I think the evidence is pretty strong, but hard to do really good controlled experiments in the population, of course, and probably mask wearing goes up when the virus is spiking, and that can lead to some confusing evidence, perhaps.
Well, and at this point in time, it would be considered unethical to have a randomized controlled trial with people being masked or deprived of mask and exposed to, the communities with COVID in it. The last point here, though, I think is really important, is here we are toward the end of February, and we just are not seeing any influenza in Wisconsin. And in fact, across the world, there hasn't been any influenza since last March. And this is largely because of distancing and masking. And it's just been profound.
And what do you say to people who say, well, maybe COVID is being counted as we're counting influenza cases as COVID?
Well, we're doing all the testing for influenza and just not finding it.
All right. Thank you. Question from James Rottenberg in the audience. Do vaccines promote virus variants? Is there a way that can happen?
The short answer is yes, it can. The long answer, it's really difficult to show. My research group has worked with Dr. Tom Friedrich in the veterinary school, and we've been providing specimens from our school-based study down in Oregon, Wisconsin. And we can see evidence of at least some evolution of viruses in the protein of the virus that the body recognizes, and is more pronounced in people who are immunized. And so we think it can happen. We don't know the level to which this is an important component of evolution of viruses, but it could happen.
We have another audience question, which we will handle offline with, I'll get some follow-up from one of you, and that is whether we can cite the science that proves masks work to prevent the spread of the virus, and has it been peer-reviewed. We'll share some peer-reviewed work that you've already shared with me. Question from Tom Brennan: can we estimate the long-term protection from the COVID vaccines, and do you think there'll be much variability in the vaccines in their effectiveness over time?
Well, important question. And one of the truisms in vaccine science is we never know how durable a vaccine is until we get there. And a couple examples recently has been the Tdap. It's the vaccine we use for pertussis. And this one has turned out to be less stellar than we were hoping for. It gives protection for about 4 years. On the other hand, the human papillomavirus vaccine, when it came out, we were hoping to see durability or it lasting 4 or 5 years, and it looks like it's going to be 10 or 15 years. And then some vaccines like our tetanus and diphtheria vaccines probably give you 30 years of protection, that we try and boost those every 10 years. But we will know much better as time goes on and we see how this evolves.
Can you tell, question from the audience again, what is behind Wisconsin's thinking on vaccine distribution, and how do we choose certain groups over others in terms of prioritization?
Well, the state of Wisconsin makes policy through the Department of Health Services, and they have created an advisory panel called the State Disaster Medical Advisory Committee. Both Dr. Safdar and I sit on that committee, and then there is a subcommittee on vaccine distribution. And the long and short is that we take our cues from the Advisory Committee on Immunization Practice, and we take their recommendations and we apply kind of the Wisconsin sensibilities and sensitivities to that to make it fit as well as we can to our state. And it's a process that goes through a great deal of public comment. All the deliberation is done transparently and in public. We don't meet ever outside of public, and we debate and try and create the best policy at the time. The policy then goes to the full committee. If it's approved, then it goes for either approval, acceptance, or rejection by Department of Health Services. In general, they have accepted our recommendations. But that's the long and short. But I have to stress the 3 pillars upon which the vaccine recommendations stand are science, there is ethics, and its feasibility. And we need to have consideration of all 3 of those before making a good recommendation.
Great, thank you. Question from Jeanette Roberts in our audience: has the combined COVID and influenza vaccine progressed? So question about whether there is such a combined vaccine in progress. And then will we need a COVID vaccine every year?
You want to take
you want to touch that one, or?
I am not aware of a combined vaccine. Are you, John?
Not aware of any combined vaccine at this point in time. And I think Dr. Safdar was, talking a little bit about durability and the future of COVID. And would you like to elaborate a little bit more on that?
I mean, I think that it's all speculation at this point, right? I think that every time there's variants coming out, our response is going to be to tweak the vaccine. And then when you tweak it, then that means you're administering a booster. So it's hard to say. I think it's safest to prepare as though we will need it yearly. And then if we find we are wrong, we'll be delighted.
Now, one of the wonderful things I think which will be coming along. I've believe that the FDA will likely allow the manufacturers to switch out the messenger RNA in the vaccines without having to go through relicensing and a clinical trial. And that's very, very similar to what we do every year with the influenza vaccines. And if that's the case, if there are significant changes in the virus, the manufacturers can turn on a dime and produce the right vaccine very, very quickly. So I think there's a great deal of hope out there and tremendous explosion in the technology and the science behind making very, very safe, very, very effective vaccines very, very quickly.
Question about treatments. You know, when he was talking about treatments, Bill mentioned at the outset early treatments using vitamins and hydroxychloroquine. What do we know about the success actually being achieved from, you know, those combinations of hydroxychloroquine, vitamin D, and zinc? Is that something that has held up as an effective treatment, or was it not? And has it been eclipsed by some of these other treatments that Bill talked about, which I assume is the case? But
yeah, you know, I think there's a very natural tendency, especially if you're a clinician, you have a sick patient in front of you and you're going to want to do something to help them. And there are existing medications that seem attractive for that purpose. And if they could be repurposed, that would be wonderful. I think this, though, is an example where we have now plenty of evidence to show that hydroxychloroquine doesn't help, and worse, may actually harm people by causing side effects. Doesn't help improve outcomes, doesn't help with mortality. And the same is true for supplemental doses of vitamin D. So I think once you have that evidence and it's sort of introconvertible and irrefutable, then it's a bit hard to justify why that treatment should still be used for people who are sick with COVID. And so I think our current understanding is that there are better treatments than hydroxychloroquine out there. And in fact, it should not be used.
Thank you. Question from James Rottenberg. And first, maybe one of you could comment about the Israeli vaccination program. You know, we talked about masking in New Zealand. Israel is an interesting case because it has pretty high density of population. Their vaccination program, how has that gone, and what does it teach us about herd immunity and the levels we need to hit? Any comment on that?
Well, anytime you're talking about herd immunity, first of all, it's not a bar that you have to hit before anything happens. As you start increasing the immunity, you do wonderful things to outbreaks. The two things you do is you tend to push them into the future and you tend to drop them down. And so I think we're seeing that happening in Israel at this point in time. But you have to keep in mind, this is happening at a time that we're seeing cases drop across the world. The other thing to keep in mind is this is a different population and it's not being done under a randomization type approach. So it's really hard to take the results from the studies there and apply them directly to what we have here. But the two lessons that I take away right now, number one, is we're seeing pretty high levels of benefit even after a single dose of the Pfizer vaccine. I think they're primarily using Pfizer in Israel. Number two, what we're seeing is people that become infected even after getting the vaccine, roughly 5% of recipients, that if they become infected after that first vaccine, after about 12 days, or if they get infected in the first 11 days, they have a higher amount of virus. If they get infected after about 12 days, they have a much lower. And that tells me something about the likely transmissibility. So I think what we're learning is these vaccines work really well initially with a single dose, and they probably have a strong effect on transmissibility. But again, we need to have more evidence of this. This needs to be replicated elsewhere.
Last question. I see we're at the top of the hour, so we'll turn you loose so you can get on with your lives and other important business that I know you both have. Should someone who has had COVID and recovered take the vaccine, and how does this provide any additional protection?
Well, I think, Nasia, you have some experience with the people in the hospital receiving vaccine after being infected.
Yeah, I mean, I think the recommendation is that because there's a chance of reinfection after you've had an episode of COVID, that you delay it until you've fully recovered and for several days after. But then once it's offered, one should take the vaccine. And I think we would strongly encourage people to do that.
And there is emergent evidence that people who have been infected and get their first dose tend to have the response that most people have at the second dose. So they tend to have a more robust immune response with that first dose. Their antibody levels go higher. But what's interesting is when they have the second dose, they tend to have a lessened effect of that dose. So what we need to do is just make sure that we're telling people, if you've been infected before, you might get more achiness, more of a sore arm, maybe some fever after that first dose that we typically expect with the second dose.
Great observation. Yes. And, underscoring a point that was made earlier, all of this, we learn as we go. This is a new virus. These are new vaccines. We don't know everything yet. And, all we can do is treat people in the best way we can. That's the only ethical way to go about things, and then learn as we go and update and try to get better. So thank you for all you do to promote that scientific process and apply it to this critical public health challenge that we're all facing. I just want to give you each a chance to offer any closing comments tonight, thoughts about the days ahead. And I'll start with Dr. Temte and then close out with Dr. Safdar.
Well, I think my last thought tonight is, after now we have immunized roughly 50 million Americans with these vaccines, we are more and more convinced of an incredible level of safety. We already knew that they were effective. We knew from the trials that they were safe, but now we're assured, once it gets out into this broader population, that these are not only really effective vaccines, but they're very, very safe vaccines. Thank you so much.
I think from my perspective, what science has showed in this pandemic is that it has taken a tremendous amount of ingenuity, resourcefulness, creativity, and innovation. And that we see in the form of these highly effective vaccines that are going to change the face of this pandemic. Having said that, I think now is the time to look forward and really try to mitigate some of these effects of lower life expectancy and the racial disparities that we're seeing, and really pull towards the future and try to reduce the negative effects that COVID is likely going to demonstrate for us in the future.
Well, thank you both for being with us tonight. Our audience, I know, really appreciates having experts like you take their time to answer their questions and share your perspectives. So thank you again. I hope to see you on the other side of this. Maybe we'll have an event in person someday. Who knows?
Sounds good.
That would be nice.
Wonderful. All right.
Thank you, Mike.
Both.
Thank you.
Take care.
Well, thanks for joining us again tonight. And we'll be back again next week, Tuesday, March 2nd at the usual time. And we hope to discuss the present and future state of one of my favorite things, dining out, restaurants. We'll have a few restaurateurs on to tell us how things have landed in that industry and what they see in the months ahead. So thank you, and on Wisconsin.
You can try, but you'll never stop a Badger. Because we Badgers are born with curious minds and endless heart. When we see a curve in the road, we speed up. When there are mask shortages for first responders, we make our own supply chain. When there's a world on pause, we sharpen our claws. Through thunder, fire, and pandemics, we'll keep going. Because after all, you can't stop a Badger.